Good morning, everyone. Today I am going to talk about how to choose an intravenous agent because we have got so many things. How we are going to choose this agent, which is needed for which case, which patient, like in a practical, simple way. So, this is our college, and our slides are freely available for download from painfreepartha.com. So what and how to choose? We have so many things. Thiopentone, ketamine, propofol is available routinely, and etomidate is available in a few centers, and methotrexate in very rare centers. We will go by scenarios. Now we will take up a routine thyroid case. What is about a routine thyroid case? Either we can induce with thiopentone or propofol. The advantage with thiopentone is it causes conversion of T3 to reverse T3, and this can intensify the sick euthyroid syndrome. I don't know whether it is of so much of clinical significance in practice or not, but thio is routinely if questioned in patients with thyroid disease. So may switch over to propofol. Now we were going to do for anesthesia for electroconvulsive therapy. What we use atropine, induction agent, thiopentone or whatever it is, scolin, mask ventilate and give it to them sometimes with a leg tourniquet. And after the current, we will proceed with mask ventilation. What induction agent? Methotrexate is supposed to be good because it doesn't interfere with seizure activities. That is very important because we are giving a treatment to produce seizure activity. We cannot give diazepam, midazolam, so many drugs which will cause problems or which will alter the seizure threshold. So ideal is methotrexate. Yes, we are going to induce a patient with porphyria. We all know thiopentone is not that good. Yes, choline we can give if it is an emergency. Gas oxygen agent and propofol is safe in these patients of porphyria. Now we go to perianal abscess because it needs intense analgesia. It's very painful area. So we need to have at least some ketamine. Yes, we induce with some drugs, but add a ketamine. So that 0.5 milligrams, or we can do only with ketamine. That's a different issue. But this is a painful surgery. The area is highly nociceptive. So we need to give some good analgesics like ketamine. But if you have visceral pain, always add opioid. This addition of opioid a few minutes prior to ketamine will definitely decrease the dose of ketamine needed, but also the property or the quality of analgesia. Now we have got an ischemic heart disease for general anesthesia. Induction. Propofol, but it causes more hypotension. Do we need this for care? Yes, we may not need this. So ideal is etomidate, which does not cause much hemodynamic disturbance. So ischemic heart disease for GA, yes, we can think of etomidate. But the problem is vomiting, myoclonus, and steroid suppression, which we should also think about. An unmarried MTP, this is common in clinical practice. TIVA, total intravenous anesthesia. We want anti-emesis because these patients are pregnant, early pregnancy, vomiting will be there. We want an anti-emetic. We want a clear-headed recovery because the patient may go out in 6 hours, absolutely not telling about this NTP at all. So we want propofol in this case. A child with a squint induction, propofol is okay, but no to ketamine because this ketamine produces nystagmus. So if a patient have child with squint, you don't need to add ketamine. No movement of eyes and no nausea. So propofol, squint will produce post-op nausea and vomiting. It does not cause eyeball mobility. So it is ideal to have propofol. It is relatively better than thiopentone because the squint surgeries are more prone for postoperative nausea and vomiting. Patients with pancreatitis. There are several reports of post-op pancreatitis in association with propofol-induced anesthesia. There are reports only, but just because every patient of pancreatitis needs propofol, if you give it, is producing pancreatitis, not like that. Yes, there is some element of pancreatic doubts in propofol-induced anesthesia in the post-operative period. Yes, if we have pancreatitis, there are some questions about the use of propofol. Better go with thiopentone. If you're going to have laparotomy and an ectopic pregnancy, pulse rate is 110 per minute and BP of 94 systolic. What is the ideal drug of laparotomy? Yes, we may need to use ketamine. But only thing about ketamine is, now this is not completely sympathetically exhausted. The pulse rate is 110 per minute and BP of 94 systolic. Now we get ectopic. The ectopic produces blood loss inside. This blood loss inside stimulates the sympathetics. And if the sympathetics are completely stimulated and the stimulation is extensive, then this ketamine is not going to produce the necessary action of sympathomimetic. So it may cause BP to fall or it may cause a myocardial depression. So that is what we need to understand. In a patient with hypovolemia or in a patient with complete blood loss, and if you give ketamine, if the patient is completely sympathetically exhausted, the so-called safety of ketamine in hypovolemic shock may not be evident. Laparotomy patient on lithium and sertraline. Induction ketamine, propofol, because we are worried about this antipsychotic drugs. Thiopentone is safe and best. Go ahead with thiopentone. You see here shoulder surgery and bronchial asthma. 2.5 milligram of propofol, significantly lower incidence of recurrence compared to 5 milligrams or 1.5 milligrams of methatrexate. So if we want to induce a patient with mild wheezing disorder, the thiopentone is questionable because it may cause bronchospasm. So we may need to go with propofol. The problem with ketamine, you see here 0.0% with propofol and 45% with thiopentone. But in active wheezing, we can use ketamine because ketamine can cause bronchodilation. But the problem with ketamine, it can cause increased secretion, which may not be very ideal in patients with bronchial asthma. A closed reduction, ortho. Propofol is ideal than other drugs because muscle tone we need to decrease. If you are doing a closed reduction, we need to have the muscle relaxation proper. We need to, where sometimes we may need relaxants, some may we give blocks. But the drug of choice, if we want to utilize the pharmacodynamic advantage of an intravenous induction agent, use propofol, which decreases muscle tone. Others, especially ketamine, can cause good analgesia, but the tone is the otherwise. Now, if you have a patient prone for airway spasm, thio is a more sympathetic depression than parasympathetic. Propofol both suppressed. Spasm is less frequent with propofol. So that is why if you want to put LME, you use propofol because the airway suppression is better with propofol. And you use fentanyl propofol. We don't need to use relaxant only to put supraglottic airways. That is one of the advantage. If the patient has got an airway spasm or if the patient is supposed to get some supraglottic airway device, go for propofol. Ketamine can be administered by multiple routes. You see here, nasal, oral, intramuscular. Useful options in pre-medication in mentally challenged and uncooperative pediatric patients. The patient is 6 years old, is coming, is shouting like that. So give some ketamine intramuscular, get the case sedated, slowly start an IV line, oxygen, start the anesthesia. So that is one of the advantage of ketamine. We cannot give thiopentone IM, we cannot give propofol IM. Yes, we can give intramuscular, nasal, oral, so many routes of ketamine is available. Penetrating eye injuries, induction is propofol is fine because already we have told no eyeball movements and postoperative nausea vomiting. In opioid addicted patients for general anesthesia, opioid addicted patients, we may need to break that thing. So we may need to use a drug which is completely different from the routine drugs. That is what is ketamine. Yes, it's an NMDA antagonist, completely different from the so-called opioid receptors. Thiopentone, rapid intravenous induction, increased ICP treatment to provide neuroprotection. These are all simple and established advantage of thiopentone. See, fibroadenoma, you use laryngeal mass cavity. Induction, either it may be GA or spontaneous. Ideal is used to use propofol because already we have told the airway spasm is decreased with propofol. The airway reflexes are better diminished with the propofol. Continuous infusion in small procedures, intermediate ketamine, where we need the so-called context-sensitive half-life. There, propofol takes over all these things because the context-sensitive half-life is very favorable for propofol, and so better to use propofol in patients with continuous infusions. See here, context-sensitive half-life. I will clear in some other things. Here it is propofol, but here it is thiopentone. Context-sensitive half-life is nothing but how much time will it take to decrease the plasma concentration by 50% after you stop the infusion. Now the infusion duration is 3 hours and you have stopped it. Half 50% how much it is. So it comes down instead of thiopentone. That is why for an infusion, thiopentone propofol is better because the context sensitive half-life is favorable for propofol. Critical illness, in particular in patients with septic shock. GA, no, intermediate because we are worried about the incidence of adrenal insufficiency because of intermediate. We know that the shock, intermediate is better, hemodynamically stable, but here it is septic shock. Adrenal insufficiency is high. That is what we need to correlate with intermediate, adrenal insufficiency, and shock. Now we have got a FES, nasal surgery, functional endoscopic sinus surgeries. We need hypotensive anesthesia. But yes, ideal is propofol. Ideal patient is going to have hypotensive anesthesia. Yes, we start with fentanyl propofol instead of fentanyl and thiopentone. Yes, in FES, go for propofol. GA in a patient with liver disease. Induction, propofol, extrahepatic metabolism 30% throughout the legs. So liver disease, we can go for propofol. GA in a patient with atopy is the induction of choice. In which is the induction of choice? Intermediate. This is the induction of choice in patients with atopic allergy because here is there is intermediate is 1 in 4 phylax instead of propofol and thiopentone, where the atopic incidence is high. So in patients with atopy, go for intermediate. For scoliosis, propofol better conserves cortical somatosensory evocative potentials. If you give thiopentone, the evocative potentials are gone. So propofol preserves SSEP if we want to monitor later. Monitoring SSP is acceptable. Better hypnosis. More than that, we have also got propofol as useful as an hypotensive agent and to maintain and continue your so-called hypotensive anesthesia. Plan target controlled infusions, propofol. What are the problems? Cost is propofol is higher. Endoscopy is good. Long-term infusion is okay. Sense of well-being noted after administration, probably due to increase in dopamine concentrations. So these are the pluses of propofol. These are some of the minuses of subhypnotic doses may be used to treat pruritus, or sometimes people use laryngospasms. Thiopentone is stable for 1 week if refrigerated, and methotrexate may be up to 6 weeks, but propofol question. Thiopentone is ideal for cerebral protection and status epilepticus, but it is not for propofol. Pregnancy for GA. Propofol crosses the placenta, but thio, even though it crosses, the relative concentrations are safer. So pregnancy, GA, thiopentone. That is towards that. It is not that every time that we should always see the patient as a whole. Pregnancy, GA, thio. Yes, it is for that. But if you think thiopentone in that case is problematic, we can use propofol. Garlic taste in the mouth with IV induction. Endpoint is loss of eyelash reflex with thiopentone, while it is loss of verbal contact with propofol. What should we need to do? Combine two drugs sometimes. Less complications may be better effect. Propofol with ketamine, thiopentone with ketamine, and newer drugs like dexmed with ketamine. All these things have come up now. 1 plus 1 is equal to 2 is never correct in medicine. There are general implications and considerations. That is what I told. General implications, atopy means intermediate. That doesn't mean all cases should receive that. The anesthesiologist should decide on each and every case.